Sometimes it's very subtle and sometimes retrospectively, and people who are clinicians often have the advantage of knowing the symptoms to look. So it's not the radiologist's fault for necessarily missing something, because sometimes they don't get any information. They're just like, a person's dizzy. I mean, but we as clinicians come in and say, oh, there's dizzy, oh, there's a little double vision. I know exactly where I'm looking, and I can kind of window things around and look for that. So, all right, one more scary example. So here's a 42-year-old woman, came to the emergency room. This is the person I took care of. She was driving down the street right across from the hospital. She was actually bringing her teenage son to the hospital to be seen in a clinic, when all of a sudden she limped over, ran into a telephone pole. The telephone pole fell on the car. The EMTs grabbed her, took her to the emergency room. She was speaking kind of funny. She wasn't moving everything correctly. And in fact, her right side wasn't moving, and she was so slurred she couldn't understand. But then new history is actually she doesn't speak English. And guess what? The person who speaks English, her son, is actually giving a report to the emergency personnel out by the telephone pole sitting on the car. So she came in, some weakness, severe dysarthria, excuse me, it was left side weakness, and confusion. So we couldn't really get a history, right? So a person comes in with this kind of thing, we're worried about a stroke, right? I mean, this is they call. So they called me, I come down, I start giving a history, start doing all this kind of stuff, look at the CT scan, which is the only thing you're supposed to do when you're giving for JACO certified stroke centers is CT scan, make sure there's nothing going on. Okay, well, no big changes on that CT scan, so what are we going to do? Does she qualify for the clot buster? She's within 3 hours. She's got focal weakness, right? She fits, right? Current evidence-based medicine and protocols give TPA, right? Perfect, we're done. That's not scary, is it? Now, let me give you the scary part. All right. The scary part is there a clot? When I'm assessing a person with a stroke, I want to make sure there's a clot to bust. I'm going to give them a potentially dangerous medication that could cause them to bleed. I want to make sure there's a clot. So we usually do a study that actually looks at the blood vessels, right? So let's do a study that looks at the blood vessels. What if it isn't a stroke, right? This isn't her brain, by the way. This is her uterus, which is what they did. Instead of doing an angiogram of the brain, they did it of her uterus because they thought it was a big aneurysm in her gut. And just to kind of clue you in, we can't do more than one angiogram on a person at a time because the dye is going to ruin their kidney. So now I can't look at the clot? Oh, great. Now what do I do, right? Do I just kind of use my superpowers or my Star Trek tricorder and look inside the brain? Well, kind of. I use what's called a transcranial Doppler, which is a cool little ultrasound. A lot of hospitals have it. Not every hospital has it. And so we actually did that. And we found that there was a lot of high velocity blood flow going through part of her brain. So could it be a clot? Maybe. But the problem is, based on my training, this number here was way too high. So here I am in the emergency room. I'm saying, you know what? This is looking kind of fishy. She fits within the criteria. I don't want to give her a clot medication. So should I be calling my lawyer, not giving her medication? So everybody's like, okay, give her TPA. And I'm like, no. So here are ER physicians, right? All these doctors tell me, give TPA. I say, no, I'm not going to give TPA. And guess what? I'm going to get sued if she has a clot, but something's fishy here. I want to know what's going on. So we did an angiogram. But further, just to kind of give you history, is that finally the actual sister of the patient came in, and she goes, oh, by the way, she had this really 10 out of 10 severe headache 3 days earlier, and she went to bed, and she only got up to go take her son to the doctor. Does anyone know what that means, the most severe headache of your life? Subarachnoid hemorrhage from an aneurysm rupture. Do you want to give TPA to an aneurysm rupture? Probably not. And so most of the stroke centers in this country would have given TPA. And guess what? If they would have bled and died, they would have chalked it up to the 6% of people that usually have symptomatic hemorrhages and just put it as that. My feeling is you have to have a little more stratification before you give people severe and dangerous medications. And so this is just a cool little picture of the aneurysm right here. Big aneurysm with a blocked artery called vasospasm. All right, so why are these examples important? So just basically to reinforce, you're not a statistic. Go to a place that you're going to get individualized, specialized care by what the hospital promises you. And then all stroke centers aren't created equally. And then all these little things just to show that I'm pretty cool at what I do, but I don't. And there's my number, which you can get anytime. And then my mantra is better to predict and prevent than to react. I can react really well. I mean, everybody knows me. I can react really well. But I like to prevent and I like to predict. And so that's my expertise. And so here's who's trained me right here. And she's showing me how to read an image right here. So, all right. So thank you. And I would love to open this up for discussion if that's okay.